Good afternoon. How are we doing? I'm Jack Chew. This is Mark Reid, and we're doing our first tandem episode just because we were gonna. Let me hide that frame. That's hiding your face. Actually, that's not a bad thing, is it? Let's put various things to obscure his face. But we were like, oh, let's do the show together, and then we realised that would be pretty pathetic if I was in this room, he was in that room, and we were like live streaming it together, especially if there'd have been some technical issues, then that would have been stupid. So instead, here we are shoulder to shoulder. So this is the first time. And the main reason, as you might have seen in the description as you've clicked on this, so thanks to those that are tuning in live, but Mark managed to like the touch paper yesterday on Twitter. He hasn't been on there for months, and then he blurts something out, and so everyone got angry, which was funny. So they've misunderstood his tweet. Some people have misunderstood his tweet, but it definitely was a topic that is relevant to discuss. And so here we are. We're going to share a mic. You're going to have to tell us if you can hear us okay, especially if we lose our mic discipline and don't keep it close to our faces. But I'm just going to show you the tweet in question, right? So Reid posted this yesterday. Do you want to read it out? You read it out and like that will help. The tone will help. Like,
so NHS physio department still not delivering any face-to-face care at all. One question: why?
I like that. Why? Right. So some people have read this as if he's saying that NHS physio departments are still not delivering any face-to-face care. So like he's making a statement to say that is a fact, that none are, right? And so that's not what he's saying. He's saying that, dear NHS physios, to the NHS physio departments that are still not. So he was asking a question, which is what that question mark means, and why. So anyway, let's clarify that. So what are you saying and why?
Why? So this come about basically from some of the work that I do, which I won't go into too much detail of, but I'll say it's occupational health in the public sector. And I spend 2 days a week working in occupational health, where we see a combination of referrals that come from team leaders to people being able to self-refer. And what we've seen over the last 6 months is just gradually more and more self-referrals coming through occupational health for physio input. But these are for problems that shouldn't really fall down on occupational health, because they're not necessarily occupationally limiting in any way. So it's, sore elbows, sore knees. The referral that really triggered this was a referral I got for a woman with a sore elbow, a sore knee, and a sore back. And she was still able to do her work. So there's no problems with work. But she'd been to the GP, and the GP had specifically told her that she would be better off going through her work physiotherapy, because NHS department at the moment isn't doing any face-to-face. And therefore she was unlikely to be fully assessed. And that's what the GP had told her. That's what she told me when I then followed up on the referral. So that was incredibly frustrating, because what's happened is the waiting time to enter the physio service through occupational health is going up and up and up and up, partly because, or a lot because, NHS physio departments in that area seemingly aren't seeing anywhere near as much face-to-face. Now, a lot of people came back to me after I tweeted that and made the case that they are seeing face-to-face. This is all fake news. They are seeing face-to-face. I can assure you that in the area that I am, there are at least some departments that are not seeing, or still seeing very limited face-to-face. And this is another question that I'm sure we're going to have to talk through, which is deciding when is suitable for face-to-face care and when isn't, because I understand that's mine.
Absolutely. Right. So I'm sorry we're having to share a mic. It's because it was at a moment's notice, as this show often does, that we've actually got 4 of these microphones in here, but can we work them all to point at this? No. So we're having to share this microphone. Now, one of the things that is clear, and so now when Mark's clarified his tweet, right, it wasn't necessarily saying that none are. And so that when someone then says, that's not true, we are, that doesn't counter his point. So let's make that clear. So when he says that some aren't, and he was irritated that they're not and asking why are you not, then that doesn't mean that the fact that you are then counters his point. That's fair. The interesting thing that we want to talk about then is, what is the average then at the moment? Because I'm hearing stories of those that are not, as Mark's just said, we hear a few different things that are happening whereby some departments are deciding to double down on virtual only for the foreseeable. We've got some that have gone back to status quo, so it's all face to face, and they've put Zoom away for a while. And then there's some, and I think the majority, I would say, I'm hearing from, that are doing an integrated model, or their initial assessments, or their triage is virtual and stuff like that. So I want to know from you guys that are tuning in live, and also if you're coming in after the fact, as many of you do get back to us on this as well. But I just mean particularly in the live chat, like, what is the distribution at the moment for you guys of how much you're seeing face-to-face, how much you're seeing virtual? If you can give us a bit of context on that. Is that private practice? Is that sport? Is that NHS? But particularly in this instance, we are bothered about NHS provisions at the moment. And I think that one of the reasons why I think this lights the touch paper, and that's the question I'm going to have for Mark in a second, as to why it does, why something like that, as well as it being just, crap wording or whatever we have been called out on, or crap grammar, is what is it about this that lights the touch paper? So allow me to offer a reflection, is that we are all customers of the NHS. We are all contributors to it. That's a bad word. Contributors to it. We are all taxpayers in such a way that then those provisions are charged. And then also, it's worth us mentioning that then the NHS is politicized in such a way that then there's an implication made to any critique, and in this instance, just a pointing out of fact in potentially the wrong order of words, that means it's more easy to misconstrue than it could have been, perhaps, if we're being generous to the critique. But essentially, the way that is read is that it's something that's so close to people's opinions, right? It's so fraught with challenge, it's so tethered to people's ideologies sometimes, that it then does trigger people, and it ends up being far more contentious than it needs to be. And so that's my offer of reflection as to why these things sometimes do just sort of take off and get pissy. And so one of the things, what you laughing at now?
Not why, it's just commented not true, and I just want to find him and shake him.
So I want you to answer the same question then. What do you think it is about this and about that tweet or this topic that then lights the touch paper? Get that under your nose.
So yeah, I think we're in a political climate at the moment where the NHS has become quite a sort of a hot topic issue. We've all been standing outside throughout the pandemic and clapping for carers, and Captain Tom's been walking down his driveway and raising hundreds of millions of pounds to help them out. I'm not going to badmouth Captain Tom. But what I will say is that the NHS is not a charity. The NHS is a healthcare service, and it's a healthcare service that is not free. It's a healthcare service that is funded out of general taxation. Okay, so you all pay for healthcare. Everyone in this country pays for healthcare in some way, but we pay for it out of general taxation. And this year, there's been a lot of healthcare needed to be done. We've had a pandemic, and because of that, there's been certain things that needed to be stopped in order to focus on COVID care and saving lives. And I completely understand that. That doesn't change the fact that we've all been paying for healthcare, and we're still paying for healthcare. And a lot of the common things that the NHS would do, it hasn't done as a result of the pandemic. So we look at, I'll take a recent example, a patient that I have who is now on a 96-week waiting list for an ankle arthroscopy. Now, that's not okay, if you ask me. 96-week waiting list. She's paid taxes all her life. She's paid for her healthcare all her life. If that was a Bupa policy, and Bupa turned around and said, we're going to charge you the same amount this year, but if you want an MRI, you're going to have to wait 3 months instead of 2 weeks. If you want an operation, you're going to have to wait 2 years instead of 6 months. If you want this, you're going to have to, you can't see these people, you can't see these people, you can't see these people. By the way, we're going to charge you the same. You would turn around and say, cancel my policy. No, thank you. I don't want that, right? Now, that is a criticism that I have and I understand why that situation exists. I understand how that's come about, and I understand that, but The NHS has had a lot more to deal with. And I'm not even for a second suggesting that we shouldn't do what we've done and we shouldn't have cancelled operations, etc. But it is just true that healthcare is more difficult to access, despite the fact that people are paying the same amount. And I think that sucks a little bit. And that's a frustration that I have. But that is a frustration that doesn't go down very well because of the current political climate and because the NHS is a bit of a sacred cow that we shouldn't really criticise.
Stealing the microphone back before he badmouthed Captain Tom. This is one of the things that's interesting about it, is that what this isn't, this podcast as a general show, but also this particular episode, is not suddenly us badmouthing the NHS. It's more that, isn't it fascinating that even a fairly factual and somewhat tepid in that tweet criticism of the fact that some aren't. And one of the things you followed up with was that it shouldn't be as much of a postcode lottery as it is generally the NHS. It's kind of a sort of famous thing that motivates many of us, including those that are involved with MSK. Physio Matters have talked about it a long time, is that it's not fair, really, the fact that there's such a postcode lottery to services. Now that that's not even the quality of the service or the access or the waiting list, etc., that postcode lottery, it's now also the style of delivery is now being so varied that if you're in the wrong postcode, you can't even qualify for a face-to-face appointment. Now, what we're not inferring with this is that there's some sort of inherent superiority to face-to-face care. It's just that there are many examples that keep emerging, that we keep encountering clinically in various different contexts, including, interestingly, I think Mark's context he outlined with his occupational health contract within a public sector and public sector provisions and keeping people in service. It's fascinating then that the amount of cases that we're seeing like that, whereby virtual isn't cutting it, or there are things that are being missed, or things that are being overlooked, or there's an element of, and I think that to some extent as well, the skill level, we've not been able to get skilled enough quickly enough with regards to virtual rehab, or the fact that you've got such varying styles of practice across the piece in MSK practice, that you've got some people whose style of care is something that you really can't deliver what they do virtually. Now, we can then make a case, and have done on this show and elsewhere, that they shouldn't be practicing this way. But generally speaking, if there's someone that is implying somewhat corrective behaviors, be that with their hands, with tools, even with their guided rehab, then they're trying to then do something virtually. They're trying to retrofit a model that they probably shouldn't be practicing, like I would argue, but also that it's just not compatible with it. So they're kind of demotivated, they're frustrated. We're hearing from them from various different types of therapists that are just like fed up with the model that they're being asked to work for. They're looking for other jobs. We know that there's all sorts of recruitment challenges as well in there. But it's just that all we're laughing at today, and we are admittedly laughing at it, is that to have that conversation and to put those cards on the table is something that just like, grow up if you're going to be so pissy as to just not allow for that conversation to take place. Now, if you've misunderstood that tweet, and there were a few people that like misunderstood it, and then you clarified, and then you had a really interesting conversation.
Back down. Yeah. Well, so there was a couple of examples where people misread the tweet as a general statement that no NHS physio departments are seeing face-to-face care. Quite a lot of people read it like that, and I understand how they've misread it, by the way, but they have misread it, and they've said that's not true. And I've went, what's not true? And I've said that I've said I've not said that, and then I've went, oh, okay, right, I thought that's what you said. However, I did have one or two who proceeded to try and tell me that actually no, the way that they've misread it is the only way that it could have been construed, and that is the way that I truly intended it, and that I was actually the author of the tweet wrong in the way I'd written it, not the way that they'd interpreted it, which was just an odd argument to have. But it's Twitter. These things happen, and I don't really care.
If you are a good enough mind reader and you do happen to be correct there, then please, you've got to teach me all that you know, because if I could crawl into this guy's head, then that'd be quite handy.
It was also the accusation that because I work for Choose Health, which is a private physio clinic, that my motivation was to promote my clinic as create the straw man that NHS physio departments aren't seeing anyone face to face, but here I can, and I will sell you my care. that's not what it was. I was actually working in the public sector when I tweeted that tweet. That was the most entertaining thing about it. That's not what happened.
Brilliant. Well, yeah, the phone's been off the hook this morning. It's been the best PR exercise for the clinic. Of course, I jest. That's not how it works. I've got a few comments here. I want to draw you guys into this conversation. Thank you for answering my call. I asked if you didn't tune into that bit. I said, are you in the NHS and what are you going for? Have you got a blended model? Are you virtual only? Are you face-to-face? We're not judging you, by the way. We know that a lot of those decisions won't be yours, but generally speaking, we know that really at this point in time, we would admit it feels remiss if you've not opened up and aren't seeing some patients face-to-face, especially those that need it, which there are many categories that seem to be emerging that do. Kay York-Jones, thanks Kay for tuning in. She said, I do both private and NHS. We're face-to-face, but still following CSP roadmap, so needing longer with patients to clean, ventilate, meaning smaller numbers of patients seen. Yes, and that is definitely something that is then driving waiting lists in many different ways, or driving sometimes frustrations, some clinicians not liking that, and some massive changes in practice that people aren't enjoying. Talita, hi Talita, she said she's in private practice only and fully back to face-to-face, but if people prefer or need virtual, then that's what I do. But always video call, never phone call. Yeah, that's interesting because, yeah, well, I mean, we felt quite equipped, didn't we, when it kicked off, because we see a lot of people from outside of area, right? Sometimes they come to us for assessment and they're willing to travel long distances, but it's quite nice because we've been quite used to managing people remotely, and also our style of practice got rehab centric and stuff. Although we've spoken openly about the fact that even with our style of care, we know that the integrated face-to-face, we were surprised how much we were wanting that and how much it was sort of really important to some of our patients. This is an interesting one from Kelly Clinton. Hi, Kelly. She said, I don't have the words to describe how upset and frustrated I am with how NHS services are running. I'm a sports rehabilitator. I have many stories from clients that are unbelievable. Kelly, I'll let Mark come in on this, but yeah, we've heard some of that, haven't we?
Yeah, we have. I'm always cautious to read too much into it, because you only really, when you work outside of that sector, you only ever see the failings. So it creates a real biased audience, really. So when everyone comes in, or a lot of the patients are coming in and they have complaints to make about the NHS, like, yeah, and it leads to a bias that, the NHS is really struggling there. When in reality, you've had 5 patients that week that have seen the NHS. The NHS department down the road has seen hundreds of patients, right? And you haven't seen 99% of them because they've not been. So mostly, I think they're doing a good job. However, there is some frustrations there. There's certainly, the way that they're running at the moment, I think there's a perception from patients. I would make the argument that virtual is actually sufficient in quite a lot of cases and probably underutilized. One of the things that needs to change, though, in order for this to work, is for patients' perception of virtual care to change alongside to meet our perception of virtual care. I perceive it to be valuable. Many patients don't. And that's a problem, because when you're delivering care that is perceived as being low value, I think a lot of patients aren't willing to accept it. And that's when they're coming down the road and making complaints about their NHS department not seeing. And I think that's one of the things that fuels that as well.
No, it's a really good point, and certainly something that you should all reflect on is that when we're taking in those stories, then you are seeing each other's failings, and that happens across sector all the time. It happens on the flip side as well. I mean, we've had pretty thorough NHS careers, somewhat reluctantly leaving them to start this place. Really, Pardon? Not reluctant. I was reluctant. Yeah, I had a cracking job. But yeah, you're certainly not getting any like generic NHS hate or straw men in here. But I think what happens on the flip side, for example, is that in the NHS you hear of all sorts of poor practice that can occur where someone's been put on an ultrasound machine for chronic low back pain for 12 sessions and plenty of money milked from them, and then it been implied that it's their mattress or some random shit that they've been told. So we know that works all across left, right, and centre. So what we're not doing then is sort of trying to paint with too broad a brush. But what I'm trying to hide that. Sorry. Is that a new one? That's a new one. Let's see what else has Kelly contributed. Sorry. I have an 83-year-old client that broke his hip. Long story about acute poor NHS care. Now that starts to overlap a little bit with some challenges that we're less au fait with, right? So we're talking about typically MSK outpatient care. The challenges that the NHS has had to face in acute services and stuff is just unprecedented, and that whilst it means there's no doubt some things slipping through the net and the quality might have slipped, but as a general rule, the way in which things have been displaced, and I think there is a comment here, sorry, it's getting really busy on the chat, especially because we pulled chat from 5 different sources, so it gets busy. But Matt Wyatt's made a point here, which I think is relevant, is that sadly a number of MSK departments have lost some or all of their physical estate to cover COVID care, vaccinations, etc. So they've no or limited face-to-face through no choice of their own. That's another, that's the thing, is that there's no, unless you can correct me, but there's no accusation.
Why?
There's no accusation.
The point of the tweet that triggered this whole debate, I said, why? I want to know why. Why aren't you seeing face to face? That point from Matt is an extremely valid point. Not only have people lost, like they've lost their physical estate, many have missed, and their staff have been redeployed. All right, so okay, lack of staffing, lack of physical space. These are reasons why that I can understand. I don't think that's going to cut it with patients.
You got to answer that though.
It's not surprising that Mark's tweet was misinterpreted, basically because it's an argumentative contrary git. Correct. It is. That's fine. And if you know that, then don't come into an argument with me. And especially if you misread it and you told you misread it.
Doubling down.
Don't.
Really.
If you told you've misread it, maybe think about it before engaging now, because I will continue to argue, and it is going to go badly for all of us. But the thing is, I don't really care. So
it's a badly worded tweet, but for God's sake, yeah, if you get a clarification, then believe the author.
Yes.
What his intent was.
I think.
Well, let's have a little read of this. So I'm gonna read this out from. Yeah, sorry, I forgot my microphone. Laura Stewart. Sorry, I can't read the whole thing. So Laura, I'm gonna just close that and say, we have an integrated virtual face-to-face service at the moment. We're a big NHS outpatient department, and returning back to normal isn't possible yet due to the numbers of people that could potentially be in the clinic room. Yeah, definitely we've been hearing about that. And the waiting room and spaces that were fit for purpose pre-COVID, let alone post. The issue seems to be more related to social media communication issues rather than NHS versus private. Yeah, I mean, this issue, things really, we're talking about they slit the touch paper and that there's sensitivities in that direction, and the misunderstanding and misinterpretation of the tweet did that. But also then the other issue, really, rather than NHS versus private, yeah, that's not the conversation. The conversation is about what is it that the NHS is currently doing. We're interested in what is the standard. Most, as we seem to be hearing, is like a hybrid model, of which we massively support. I think that's a really smart thing. I think those that I'm hearing about that have reverted back to old normal, I think it's really clumsy. If you just happen to have had the space to do that or the service volume. One thing I haven't brought up yet, which I'd be interested if you're in the chat and you're still tuning in live to join us with, is one of the things that I'm probably most perturbed by, more than the sort of delivery style, which we've been talking about, is that some departments, when COVID hit, they didn't just then clear their lists, they cleared their waiting list. They offered they weren't accepting referrals for a bit. They had a block on. And whilst I understand that, if they didn't then flag it or notice it, or it's just that they've then ended up in this situation where for a period of time, they were, in one case, this was an 8-week period of time where the service wasn't running apart from for seeing out people's caseloads virtual only, not accepting referrals. And then I've heard of even higher than 8 weeks, but I know this one for sure. And that then has meant that this backlog, this wave that has come, and apparently in recent weeks as well, hearing from people that's getting this massive wave of referrals, because as people start to use their body in interesting ways again, it's like first round of golf and stuff like that, of course, or when they're asking different things of themselves, then they're starting to notice things that they want to get sorted. Their exposure to function has meant that they've then spiked. So that's one of these things that's proliferating waiting lists. So I wondered your thoughts on that, guys. Really appreciate everyone's comments. I'm sorry, we're definitely not going to be able to get to them all. Paula Deacon has said, Mark was spot on. Patient perspective of how can I have physio over the phone is a common question. That's something that I think we need to work on. And also I'll allow myself to be controversial rather than him for a change and say that some of the same people that have been implying that the magic is done with our bare hands are then pissed off that the patients won't pay for them to see them virtually, right? just think about how ridiculous that is. Some of the same people that have been implying that the special source is in our hands rather than our words, in our rehab, in our functional guided exposure style care, are then frustrated that the patient that there's a difference in how the market perceives our expertise, right? You might well have contributed to that, Bella. I'm afraid it's annoyed me. But can you, really just talk a little bit about what you think the downstream consequences are of not having a joined up? Let's say we seem to agree that the hybrid model we like, right? The sort of face-to-face virtual hybrid model. But what do you think are the consequences if by postcode that varies significantly in provision? What do you think will happen downstream, sort of societally?
Yeah, so I think physiotherapy already struggles a bit with perception, you know, in the way that the profession is held in esteem by the wider public. I don't think we're held in as high esteem as consultant orthopedics and others, and even GPs. And I think it adds to that problem. Really, it compounds that issue when some localities are perceived to not only be not offering good care, but offering it virtually or over the phone. I think the biggest issue I've had is most of it's not virtual. It's actually people getting appointments over the phone, and they're saying, like Paula said, how can we do physio over the phone? It doesn't make sense. And the downstream consequences of that are just the reputation of the profession again. And I think it has consequences for general health. If people are going to be less likely to consult physiotherapists for their sore bits, I don't think that's a good thing, because I think the physiotherapists are one of the best equipped professions to deal with people's MSK problems, both in diagnosis and in treatment. And if people stop doing that because they perceive it to be low value or a waste of time, or I only got it over the phone and how can you do physio over the phone, I think that has some consequences for the general population's healthcare that I don't want. And I think it has consequences for the wider profession in the way that we're viewed. Sure. And that's not a good thing.
Just read this one from Johnny.
So Johnny's put, hybrid model in our service. Amazing how patients after having virtual really like it, but prior are dubious. Following first initial face-to-face can be accessed if deemed appropriate and required, as per Matt's point, loss of clinics for use. Absolutely. And that's the thing that I've noticed as well, is that when people are sort of a bit skeptical about how virtual might work, and after they have that first appointment, they're like, brilliant. And sometimes I've even been through an assessment with them virtually and said, we can do face-to-face appointments if you'd like, or we can do it virtually. And they've actually opted for virtual. Like, that happens quite often. So it does happen. And I think giving patients the choice is a really good thing. Where I get a little bit skeptical is when the clinician is making the decision on behalf of the patient. The clinician is deciding whether or not this case is worth seeing face-to-face or virtual, and the patient doesn't have any input. And I think that goes badly, because sometimes the patient may believe that they need to be seen face-to-face, and if they're not, they're going to have bad outcomes. And that's where I think it goes wrong.
Yeah, exactly. And I think that patient choice is something that is so seldom brought forward, really, as well, because it's become a bit paternal. I think the pandemic's done that to us as well as healthcare professionals. I think there's something a bit lofty. I think we have started to not all the time, of course, not all, hashtag not all, not true, not all the time, but we do sometimes seem to think, well, we know what's best, we know what's safe, with the people that can pass our hand hygiene audit better than you. There's some sort of weird lofty medicalization of expertise that's occurred. Now, last couple of minutes then, I just want to pull this up. I know you've just read Johnny's thing, but he goes on to then say that, as per Matt's point, loss of clinic for use in COVID care is a huge factor. Alongside loss of 50% of the workforce to redeployment, that is huge. And that's why all of the things we're describing, we're not attributing some sort of narrow responsibility to one stakeholder group or departments, or certainly not the clinicians themselves, especially if there's any of us sat there raging, thinking that we're having a go at you as if you've got much choice in this matter. But when it comes to this, and Johnny, I suspect that you'll have seen some of this stuff when it emerged, but when I hear about the workforce challenges that are taking place and people still scrambling to sort of get their departments back on track after various different waves of redeployment, I really struggle with that because of the work that I tried to do to say it's probably not a good idea for your consultant grade and advanced practice physios to go and work as porters at the hospital. Right, I was that guy. And so whilst it's not a fun I told you so for me, and it doesn't mean that those challenges then don't exist, the ways in which those were small p political decisions within the health quangos that occurred, as well as some of the large p political decisions that were then influencing that sort of stuff. But there was a massive attempt by me and others to try to make some of those policies more sensible. You never know; the counterfactual might not have existed to the good effect of what I'm talking about there. I'm not saying that if only they would have implemented my policy, the world would be a better place. But generally speaking, a sensible redeployment strategy that then spoke to people's individual skill set and helped people to bolster a rehabilitation model that we'd still be using. Right? It wasn't just for COVID; it was for COVID displaced patients. So when I hear stuff like that, and I agree with it, and I know that that's a big factor affecting things, it is ridiculous just how poorly this has been managed by managers and managers of managers, right? And that they are so rarely in the ire of people on this, right? Everyone finds it the world's easiest thing, and rightly so, to shake their fist at the governmental ministerial positions making these calls, and we're no fans of them, right? But the way that the health quangos have dealt with this and the way that they are then so far away from any public scrutiny is fascinating, because some big calls were made and some bad calls were made. Again, in our position, love to chew that over if anyone wants to challenge us on that and get stuck into those weeds. But for now, let's wrap up. Schumacher's put a decent point here as to finish, which is we're both a bit bolshy today, and he's expecting a mic drop moment at the end of this. Well, this mic doesn't drop because it's on such a fancy boom pole, but yeah, I know what he's meaning. We have been a bit leery, so hope you've enjoyed it. Thanks so much for the.
I'm just being myself.
Yeah, he's actually on a calm day. So yeah, thanks a lot, everyone. Really appreciate it. And sorry we've run out of time, but yeah, I'm sure we'll chew this over again. That tweet again, just to stir the pot a bit. That's what Reid said, and isn't it badly worded? But do you want to finish off by just saying why again? I enjoyed that.
Why?